So I want to thank our esteemed panel here on informed consent. I think the most expeditious thing to do right now would be to open up the floor for questions. And I see somebody going over to that mic.
Hi there again. I just wanted to endorse the idea that there's room for some change or improvement sort of regardless of whether the ANPRM is adopted in our lifetimes. Michael presented a set of open-ended questions that research coordinators or whoever it is that it's obtaining informed consent could ask of a subject. My colleague Nancy Cass and I did a pilot study, the paper for which will come out relatively soon, where even just asking those questions, when we assessed understanding, there was a little bit of increase, nothing dramatic. But the thing that I thought was really endorsed this was that the research coordinators, project coordinators that we worked with on the trials that we were piggybacking our assessments on loved it, that it gave them the sense that they could ask and get answers to open-ended questions that let them know they were doing a good job. Otherwise, they may not get some of that feedback themselves. So I think there is some room for, not to say that it's completely simple, I think it does need to be taught, and there needs to be some practice in what the answer, if they give a wrong answer, what the person ought to say in terms of clarification. But I don't think any of that requires a regulation change. It's more of a culture change that I think might be possible.
And possibly a training change.
Yeah.
One thing that could support that training change is also just a pilot. I'd like to do more work in this, but we did an activity where we sent the research nurses home and said, take one of your consent forms and create for yourself a teacher's guide of that consent form. Because actually most teachers have there's a curriculum, there's a teacher's version of the curriculum. If you go into a classroom, there's actually a teacher's version of the textbook. And so with one page, explanation of what it would take to make a teacher's version of your consent form, introducing these questions, the people who did the homework changed how they communicated with patients. The people who didn't do the homework, well, they didn't change anything. So there are ways to integrate this into the flow of how you work with staff and develop professional development work.
We're here. Okay, on this side, she's passing over to you.
Do you want to go, Steve?
Steve?
Carol, you're up. All right. Thank you, panelists, for lots of food for thought. I wanted to ask about something that I didn't hear any of you speak to, which is some of the more innovative approaches in the, I guess I call it the community engagement camp, things like community advisory boards, or approaches that go outside of the consent form, consent process entirely, to, for example, cut down on length by increasing public literacy, scientific literacy generally, so we can take whole sections of what are currently in consent forms, things like optional studies and what it means to donate biospecimens for research, just because we've improved the public knowledge about what it means to donate biospecimens for research. And if any of you have comments on that.
We have, as part of NCI's Community Networks Program Center, U54 program, we have one at our site. And the pilot project that we did was on informing older, underserved African-American residents of the greater Detroit metropolitan area about the issue of biospecimen banking, biospecimen collection, and so forth. And we did a series of very engaged focus groups, very engaged interviews, and developed a pilot workshop and along with video and so on to provide a community-based educational initiative. This has been published is going to be published, has been accepted. I should also say that in developing that, we use, because that model for the CNPCs is based around CBPR, we had our community advisory group, our stakeholders in the community, involved with us in planning that research process with, moving forward. And so at all stages, there was a very strong community voice.
I would like to add something to that too, and I would like to see, even at younger ages, you know, you hear parents say, "Oh, my kid's so smart, someday he's going to grow up and cure cancer." But the second part of that is, well, that involves clinical trials, you know. So getting that nomenclature into the schools earlier, that, you know, when you're thinking about what you want to do, and some kid might say, I want to, you know, I want to work in cancer, but that involves people. That involves trying risky things in people. So kind of getting that thought on a local level. And I think there are some patient groups who have kind of gone that direction. I haven't heard a lot of feedback about that, but I think education can start about cancer clinical trials, and human participation can start a lot earlier.
Yeah, and this isn't directly responsive to your interest, I think, in enhancing public education, but a lot of my work has been in newborn screening and biobanking and that sort of domain. And what our group and other groups have done is try to do that public outreach to say what it is, what do people want to know about how the process works, so that they can be adequately informed to make a decision one way or the other. And I think the general theme in that literature is folks have selected categories of stuff that they want to know, but they don't want to know all the details. And a lot of times clinicians would say, well, if we're thinking about informed consent for newborn screening, do I really have to talk about 30 different conditions that are on that panel? And the answer is no. People don't want to know that sort of information, but they do want to know a couple core things that help them understand basically what's going on. So I think that sort of engagement is very helpful to put on a stronger evidence base exactly what you need to tell folks or what you need to talk about in order to make sure you're supporting a adequate decision process.
Not to make too spicy a comment back, but you know, we have a system, we have a society where most of the school funding comes from local property taxes. So if you just think about the enormity of the problem, it's actually massive systemic problem. So you know, if you do focus groups in poor neighborhoods and you say to people, you know, let's go through this HIPAA stuff, and people are like, use my information. You're going to try to help me. Use my information. Of course. No, it's just totally different cultural assumptions about all of this stuff. You know, all of this stuff. So absolutely, we should be doing science literacy. But we should also help people stay in school. We should actually fund the schools, like the pay teachers. I mean, it's everything. You know, it's everything. Anyway, I'm sorry to be so spicy.
No, and you've all spoken more to something even more grassroots than I was thinking of. I was really thinking more community engagement by patient advocacy groups and with, you know, communities, whether it be cancer patient communities or, you know, broader groups, but working in conjunction with an entity like the NCI to sort of raise the level of knowledge. You know, maybe I'm Pollyanna, but I think that's something that could really help reduce the size of the consent forms and promote more knowledge that it would be upfront before we even get to the consent process. So.
Basic knowledge.
Well, one more quick comment, if I could. One of the things that some institutions done a good job with, and we're struggling to break some barriers our institution, is just to brand our institution as a research institution. And folks who walk through the door don't necessarily have a basic understanding that that's a big part of what we do, and that we do tap into their medical records and we do use their residual clinical tissues and those sorts of things. So what we want to do is raise the awareness of the importance of research in general as a whole part of the process, as opposed to making it something extra and special that maybe you're introduced to or maybe you're not. And I think that at the institutional level, there's a real opportunity to do a better job with raising the profile of research, because a lot of folks are scared of research. So we ought to kind of decrease the valence of that conversation.
So I just want to endorse something that Mary McCabe said early on in her remarks, where she talked about this controversy within the working groups about whether to talk about the standard of care or what the usual care practices would be within a trial. When I was learning to have informed consent conversations with patients and families, I'm a pediatric oncologist, and 15 years or so ago as a fellow, I was watching my mentors have these conversations, and the conversation would start with a long discussion of the clinical trial. And then after that was over, a very brief discussion of the alternatives. And the frame there was the default is the trial, and here's the thing you could do if you somehow decide not to go on the trial. And about 7 or 8 years ago, my colleague Rick Kodish at Cleveland Clinic published a study that was based on very intensive engagement with parents of kids who had been through a clinical trial experience, where the parents clearly said, we want to hear about usual treatment for our kids' leukemia first. And after you're done telling us about that, then we can think about the clinical trial as an alternative, and we can actually make an informed decision as against the other thing that we might do, which is to receive usual care. Flip the presumptions entirely on its head. So I was really glad to see that in the template, the structure is set up that way with a brief discussion of usual care first, and then we move on to a discussion of the clinical trial now that there's a point of comparison for how it's distinguished.
And the patient advocate groups get all the credit for that.
Just along those lines, people, when you have a whole list of risks and all the side effects, the cognitive decision is the added risk of the research over against the other stuff if I choose to do that. I mean, and sometimes, that's another issue, that you could choose to do none of this, but that's a whole other part of it. But, how to discern the added risk from the research component is, it could help make these things much shorter, but it assumes that all that other consenting is going to happen too. But when you had these experiences, when you were observing your mentor doing this, was that explicitly presented to you as your training for consent, or you just were trying to soak it up?
It was just what I observed. I don't think it was explicit in anybody's mind. I think it was just the way they had learned it from their mentors, who had learned it from their mentors going back to 1847.
Right. So I think that this real opportunity to kind of concretize around, methods and, what is the training? What is the professional development that's needed? We have a whole core of people, research nurses, other people, basically without adequate training.
Thank you. And then over here.
Angela Bradbury from the University of Pennsylvania. Thank you so much. I think it was very great to hear of all these new ways to think about the informed consent process. I was particularly intrigued by Jeffrey Botkin's comments about the incentives, and it made me think about the challenges to implementation. So even were we to find a great process, I guess I wonder and I ask what are all those other barriers that we might meet in implementation? It makes me think of dissemination and implementation research, where you want to design your intervention from the very beginning with an understanding of all the stakeholders. So I'm interested in what's known among those different stakeholders, because I wonder if they will be a barrier to any improved informed consent process.
Well, I guess probably a much quicker answer than that question deserves, but it seems to me that all of the stakeholders recognize the problem. So at least at that level, I don't think you have folks out there saying, no, we got it right, and I don't see any reason to change. But I don't think anybody's going to willingly change on their own unless there's a broad systemic change at the same time, because I think there are too many difficulties with being in the vanguard in this particular. Now, maybe you get an institution or investigator who's willing to sort of take that on, but I think in terms of systemic change, the kinds of incentives that I listed seem to me to be fairly overwhelming. I'd love to hear anybody else's, maybe that's a little too skeptical, but that's why I think it's the regulatory or guidance change that would be necessary, and really to get everybody on the same page to say, okay, we really do have to figure this out and do it right.
Well, and as a practicing oncologist, and I think about our clinics and how they operate and changes in the healthcare system and changes in the funding levels, I think it, will really take some sort of push. So it's interested in what other people think will be necessary.
Thank you.
Well, but it's been, there's been attempts to include regulators in the conversation at different levels, so that, when we were making the AHRQ toolkit, we included people, regulators, and, at multiple turns, they managed to make it more complicated than we wanted to have it be. But independent of that, now we have this toolkit, but no one uses it, so
Yeah.
very nice. But there's this Pinocchio worry, like if you're going to set your institution out ahead and, someone's going to cut your nose off.
Okay. Over here.
Michelle Christian, I'm a medical oncologist and member of the National Cancer Policy Forum. So just one quick comment about the standard of care. I actually like the recommendation or the thought that one might start with that, because often I find the toxicities associated with standard care are never made clear to patients, so they really don't have a context in which to look at the added toxicities of treatment. But my question is that other than the interactive tool, which I thought was terrific, there wasn't much discussion about audio-visual videos and other things that might be used to overcome some of the time element involved in consent and some of the reading requirement as a way of helping to inform patients and then allow the physician to spend more time confirming comprehension. So is that I mean, in this area, you would think there'd be a lot of tools in the audio-visual arena.
As you might imagine, from a data perspective, I sort of jump in. A couple of things. First of all, I think clearly the wonderful work that Michael's doing. There are other R01-based efforts around the country that are going on. Dr. Neil Maripol in Cleveland has a multi-site study we've been a part of, where he has extensive. It's a video preparatory activity for patients going forward into the visit with the physician, anticipating if a discussion of a trial takes place. These are the things to think about. So it's a preparatory aid, and it is very much tailored around the basic concerns and values of the patient. We had an interesting experience with it, however, because we have we have a 47% illiteracy rate in the city of Detroit, and so even and at an audio level, even a number of the terms that were used and the issues that were raised were really very difficult for our patients to comprehend. There's also the issue of setting up a patient for the possibility that a clinical trial may be offered, and then if it's not offered, somehow am I not getting the latest and greatest care? So we have to be mindful of that. We have in our studies, we found patients coming in looking for a trial and saying, where is this? And if we don't offer it, then that sets up a series of issues. I also want to say, though, that we had an R21 project to look at the choreography of the clinic system. And coming back to the issue of the system and the fact that, at least in our model and the way we've conceptualized the consent process, we start with that very sacred relationship, we call it, between the patient, the physician, and whomever, if the patient has someone with them in that visit. And then moving out from that process, because that's the point at which we see the discussion of a clinical trial or the option for a study, a protocol, to be introduced. And so many things get shaped around that idea. One of the slides I didn't have time to show was the result that we had from our R01 study that we published in JCO. And in that study, we found that the decision that the patient reaches about whether or not to accrue is based very much around the relational communication, the how it's said part that goes on between the patient and the physician. And in fact, then, one of the things that happens is that there's a disconnect between the physician talks about this, may or may not go over much of the study, but it, provides a very patient-centered, caring, empathic kind of rapport with the patient and with the family member, and there's synchrony, and there's accuracy and some shared agreement. Physician leaves the room, and somebody new comes in, completely disconnected with the previous process, has a very different tone of voice, has a very different face, can be a very, very nice person, but that's not the doctor, and comes in, and then there's some history taking that goes on again and again, and then there's the consent form, and may or may not provide information that's consistent with what the physician has said about the same study. So what we tried to do was a study where we could perhaps introduce an intervention where patients who are eligible for available studies are screened beforehand. The research nurse, the collateral people, come into the room with the physician and the patient and the family member. They They sit in the background, all right, but they have the imprimatur of the physician there. And it actually is a little shorter for the physician because the basic key elements of the study, of standard of care and of options, and there may be more than one clinical trial that's an option, of course, and then that physician leaves and the details are covered by some very skilled people who I'm led to tears sometimes when I watch how they talk with patients and the questions and the concern and the issues that are raised. And then that person becomes a lifeline for that patient going forward throughout the rest of the decision process and into the treatment. I'm talking a lot and I apologize, but one of the things I'm trying to say though is that we didn't get a lot of uptake for that study. It was a pilot study. And one of the reasons was that we didn't have a system that had the incentives in place to really support the pilot and the intervention to really work. So we've got a lot more work to do, I think, in terms of the research that we do to make a sea change in the ways in which our systems are set up and choreographed to support our patients.
Absolutely. And I think that big sea change, I think we've heard a bit about the emergency for that, the urgency, I shouldn't say emergency, the urgency, the time involved, and that this is a dance. This is a relationship-based process, and that there needs to be changes in those relationships. There needs to be things in place that will help the cancer patient, and also one more thing. We're cutting into lunch.
So, Jeffrey, can you hang that hook on that regulatory language? Require comprehension as a entry criteria?
We're going to try, and I think we'll have to see what our OHRP colleagues have to say about that specific issue. But we'll keep weighting it up till it breaks and then back off a step.
Okay. Thank you so much to the panel. Thank you for the great questions from the audience. And I'm not sure if lunch is outside or right outside, Cheryl says. All right. Thank you very much.